Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm talking with Jeremy and Doug, and we're going over a new course. It's been around for a few months called FCCS-RL, Fundamentals of Critical Care in a Resource-Limited Environment. How are you guys doing today?
Good, thanks.
Great, thanks for having us.
So, if you, Jeremy, if you would you mind doing a very quick introduction?
Sure. So, hi, my name's Jeremy Tamplin. I'm a critical care medicine physician by training who spent most of my career in burns and trauma critical care, mostly down at the San Antonio Brooke Army Medical Center and the Institute of Surgical Research Burn Center. Worked with the ECMO program, starting that up there, and then became involved with the problem that we're talking about today through my efforts, as well as many others, including Doug's and Dennis's, to deliver telemedical support to prolonged field care providers through the Advanced Virtual Support for Special Operations Forces project initially, and now that's transitioned to a broader group, the Advanced Virtual Support for Operational Forces. And I'm currently the director for the Telemedicine Advanced Technologies Research Center here at Fort Detrick, Maryland.
Outstanding. Doug and I have done, 10 or 15 podcasts together, but if you happen to have missed all of those, Doug, would you mind doing a real quick introduction?
Sure. My name is Doug Powell. I have been a critical care medicine doc, just like Jeremy, for about 15 years now. And my career has included clinical phases in intensive care units in the military and operational phases with special operations units, where I've been privileged to help develop and deploy prolonged field care teaching and practices.
Outstanding. So let's just start this off. What exactly is FCCS-RL?
So FCCS Resource Limited is the Fundamentals of Critical Care Support course in resource-limited environments. Originally intended to be called Fundamentals of Critical Care Support course in austere and operational environments, but because the course is really owned and operated by the Society of Critical Care Medicine, and they have a global reach, there are a variety of customers across the world that don't understand what austere and operational environments are, so we've made that a subtitle. So now it's just the FCCS Resource Limited, and is a course designed taking the basics of Fundamentals of Critical Care Support course, which is really looking at how caregivers who are not critical care trained can provide critical care support in really well-developed kind of Western medicine-like hospital systems. And I'll let Doug talk a little bit more about it, but when we have tried using the FCCS basic course to train caregivers, so medics, general practitioners, PAs, nurse practitioners, whoever it may be, in how you might deliver critical care support in a prolonged field care environment or on a steer and operational setting, we realized that many of the principles and the way that the FCCS basic course taught people to think really wasn't sufficient for the environment that we intended these practitioners, these caregivers to work within. So we had tried modifying the FCCS course over time. Again, I'm going to let Doug talk a little bit more about that, but it became apparent that we needed a better course. And so the partnership began with the Society of Critical Care Medicine to create was now FCCS Resource Limited.
Yeah, thanks, Jeremy. I think, from a standpoint of this course, I represent, and some of my fellow special operations medics and docs represent the demand signal that the concept of getting core critical care capabilities and knowledge for non-critical care trained providers is a big part of being ready to take care of critical casualties when you don't have golden hour medevac or role 2 surgical or role 3 hospital capabilities nearby. And we did actually do some trials with the basic, the core FCCS course. And exactly like Jeremy said, it didn't really meet the demand that we had for knowledge, and especially for application of the much fewer resources we had in these environments. And so we were really grateful that the society really under a lot of influence from Jeremy and Matt Borgman were willing to develop this new course for us. And having taught a couple of courses already and gotten the feedback and seeing how the guys take to it, I think we've got a really powerful tool to help prepare units for prolonged field care in austere and resource limited environments.
Who's the real target audience for this course? Like who are the lessons been designed around? Is it physicians? Is it nurses? Is it medics? Or is it everyone altogether?
Yeah, it's probably worth saying that, when we first started imagining the need for the course, the demand signal was coming from kind of special operations community and that environment. But as we talked about it, and as we started imagining the content that was needed for it, and even as we started kind of teaching some of the modules, writing some of the modules for that matter, we quickly realized that the way that you need to think in a austere setting in order to provide best possible care along kind of the constructs of the minimum, better, and best model, it was apparent that many, if not most, Western-trained clinicians, whether they be nurses, doctors, pharmacists, respiratory therapists, any of the roles of care that you find, surgeon within the Western medicine system, really had difficulty considering how to best provide care within a resource-constrained setting without the ability of having evacuation or transport. Many people's skill sets in those environments end with, oh my gosh, I don't know what to do. I need to get this person out of here. And their focus then becomes, really pivotal on the need to evacuate and the need to transfer. Oftentimes at the exception of being able to provide the best possible care for an individual that's within their care for a period of time. And it was really in that space that we were able to, kind of talk to the society about, what kind of a course this might represent for them. And it became not just a military course, but really a course designed caregivers who might go overseas to help in a disaster medicine type environment or humanitarian aid situation, but really for any caregiver who is forced to deliver, who is by necessity forced to deliver critical care to patients outside of their typical comfort zone, as might be seen even in the United States now with the COVID-19 crisis in places like New York City and now Florida and soon to be potentially in Texas, where we have caregivers who are not critical care trained helping to manage severely ill patients with organ dysfunction in places like the emergency department, on the wards, and sometimes either in makeshift or ad hoc COVID units that are even outside of the traditional hospital environment in places like churches or gymnasiums. And these caregivers, are forced to deliver, the best possible care with their limited experience or limited training but without the ability to evacuate these patients to some other location because there really isn't any bed capacity anywhere else. And it was in these spaces, so disaster medicine, humanitarian aid, pandemic support, and obviously in the military use case of prolonged care, prolonged field care, that the society allowed our group, myself, Matt Borgman, and about 40 other authors of chapters and teaching material, both from the military and from the civilian sector, to produce the FCCS Resource Limited course.
What would you guys say is the maybe the one or two or three things that are like the main focus of this course? Like if you're going to leave with anything, it has to be these, 2 or 3 things.
That's a really tough question to answer and to boil down kind of all of resource limited critical care into, 1 or 2 things. I probably have an opinion. I'm guessing that Doug probably has a slightly different opinion. I would guess, that same question of most of the authors, there would be slightly different opinions on this topic. But if I had to try to kind of boil it down into a couple of pieces, at least the way I think of it, it may be more than 2. The real the real necessity of how to do critical care in a resource limited or a severe medical setting is the way that you think about it, right? And a lot of the ways that you think about providing care in this type of a space really relate to how you plan to provide the care in this type of a context. So the more you plan, just like any good, op plan, the more you plan ahead of time, the more flexible you are with your response when the plan doesn't go as you intended. So, having a good PACE plan and understanding what your options are for delivering the best possible care in your context is probably one of the core components of the FCCS Resource Limited course. I would say the other real core component of the FCCS Resource Limited course is the willingness to ask for help and to realize that you may or may not have all the right answers. So we emphasize the use of telemedicine a lot. Telemedicine doesn't necessarily have to be advanced remote monitoring with video teleconferencing capability. It can be as simple as a text message, an email, or a phone call. Making those, whenever a question comes up that you don't know necessarily what the right answer is or you haven't come across before, making those phone calls, making those connections with others who may have more experience or may just have other thought processes can certainly decrease your cognitive burden, but can also increase the options you have available and ultimately deliver better patient care to the person in front of you. Doug, your thoughts?
Yeah, I think I 100% agree with you that the main benefit of this course, and if people come away with the main benefit from this course, is that they learn to think about delivering, good quality critical care with limited resources over a prolonged period of time. And as a corollary to that then they have confidence that in their ability to do that. I think so much of being successful at critical care in general, but also critical care in resource limited environment, is your belief that you can manage these patients for an unknown amount of time, no matter what your resources are. And just that mindset at the starting point makes a big difference in how your patients will do. As a corollary to Jeremy's thoughts about the importance of preparation and planning, training is obviously part of planning, and I think that the resource limited course will emphasize how important it is to train for these scenarios before you encounter them, rather than react to them when they actually happen. And we try to stress in the course, a bunch of different plan A, plan B, plan C eventualities where, you don't have this resource, or you have X number of resources and you have Y number of casualties that exceed your resources. Well, how do you allocate them and get you to think about that? So those, I think, basically parallel Jeremy's top two priorities for what people should get out of the course and what the course overall is aimed at delivering.
Dennis, I might highlight a couple of other really key kind of differences between the FCCS Resource Limited course and the kind of FCCS Basic course, and some of the challenges that many of the students have, maybe not always from the special operations community or kind of the medic community, but certainly from the credentialed provider community. So, nurse all the way up to, to experienced, a physician provider. And, the FCCS Basic course, just like almost all of medicine right now, has this heavy emphasis on diagnostics and testing, and the ability to use technology, lab tests, invasive monitoring, imaging studies, all of these tools that are kind of ubiquitous and easily accessible in the Western world, even in the setting of COVID-19, aren't always available in the resource-limited environment. So, the expectation for what is standard of care in the resource-limited setting becomes a challenge, because many of the folks that are used to providing some specific standard of care based off of a guideline or based off of their experience or based off their hospital system's preferences, just isn't possible in the resource limited setting, and it can cause some elements of almost paralysis of thought more than anything else, because people don't understand that there are still options of delivering care, even in its most basic form, which could just be comfort, pain control, positioning, or just mental engagement and compassion in some of these settings that people just forget that those are parts of medicine sometimes because of all of our technology, and those become really important conversation points in most of our FCCS resource limited courses.
Yeah, definitely. I agree. Having taught 6 of the courses so far, which tells you how short this course has been around. I think one of the things that a lot of people get out of it, or maybe are not medics and aren't used to having to think this way, is just the alternate orbits, I guess, around this patient. So not only the direct care that goes to the patient, but all the ancillary things that need to happen in order to make the situation better. So things like sanitation, nursing care. Obviously, the nurses think of that, but not everybody does.
Yeah, I think people forget oftentimes one of the most scarce resource in a resource-limited setting is the actual clinicians and the clinician types, right? If you only have one doctor, but you're caring for 300 patients, the ability to spread that one doctor's expertise and hands around the 300 patients is very limited. Same thing with nurses, same thing with respiratory therapists, same thing with medics. If you're at a 300 patient mass cow, the probability they have enough medically trained clinicians or caregivers in that environment is just low. And you need to understand how to leverage or how to, engage with other sets of hands, other resources, other people, so you can get the kinds of help that you need. I would also just kind of highlight in that same space that, there are often few right answers when you're dealing with resource limitations and casualty numbers. So if you have many casualties, or if you even have one, what the right answer is in terms of what care you deliver is oftentimes a judgment call. Do I give this antibiotic now, or do I save it for later? Do I give this pain medication now, or do I save it for later or for another patient? All those types of questions come up because you just don't have enough resources, enough medication, enough bandages, enough monitors, enough fluids, whatever the case may be. And, the questions often arise, when and where should I use certain resources to their best effect? And oftentimes those are good discussion points within the course in order to provide a framework with how to think about and how to best utilize your resources to get the best outcomes you can.
Yeah, absolutely. The entire course, I think, is designed just to stimulate thought and questions. And with the scenarios, the instructors can take it many different directions just to stimulate, even just another couple more thoughts about, well, if this was a situation, I would do it differently than what was presented, I guess.
And I'll offer, it's not always the instructors that do this. Oftentimes there are students that are within the, so we didn't really talk about how the course is structured very differently. It's not a didactic course. So the course is very interactive. It's case-based. It's case-based with short didactics that are interspersed throughout the cases to, kind of make sure that everyone has the same material available to them. But the conversation that goes on around those specific cases and around that material is oftentimes very rich and oftentimes very diverse. And I would say that I've taught a few more courses than you have now, Dennis, but not many. And almost every time I teach a course, I actually learn something from one of the students about a different way of either managing a problem that we present in the course or a different way of thinking about one of the problems that we present. And many of these are ethical challenges as well.
Let's see. So I guess shifting just a little bit. Right now, as far, I believe it's DoD wide. If it's not necessarily maybe SOF specific, but going to other places such as like Africa, things like that, there is a requirement to attend a prolonged field care course. And with time constraints and money constraints and things like that, do you think a FCCSRL course would suffice as far as pre-mission training?
Dennis, this is Doug. I'll take that one first, if that's okay, Jeremy.
Certainly.
Because I have, firsthand experience of having to prepare one of the first special operations units to take on that mission, to take on that type of mission, and my answer to that is no. FCCSRL, I think, can be a very important component of pre-mission training for deployment to austere, resource-poor operational areas like Africa. But it's only going to provide didactics and discussion and thought development in a classroom environment. And our experience is that it's very important to cement those lessons from the classroom with hands-on experience, with scenarios, field exercise scenarios, basically for repetition, and then also to actually go through, the physical and mental hardship of taking care of patients with very little resources, having to improvise on the fly, having to be awake for 24 hours and figure out sleep rest cycles, and probably the most important thing that needs to be provided in addition to a course like FCCS or material like is presented in FCCS Resource Limited is training of the non-medical teammates on those missions to do basic medical tasks to support the main medical providers and basically be provider extenders, as Jeremy talked about earlier, where you have, one provider spread across, too many patients for them to see, efficiently without either ignoring patients or burning out.
Yeah, I definitely, just from my experience, both with FCCSRL and other prolonged field care courses, I think the target is definitely different for both of them. I could see FCCSRL as like a kind of like the cherry on top, where you have some very complex things and we have time to discuss it, but we don't really have time to play the scenario out, real time. Versus,
I might take a little bit more of a pragmatic approach too for the issue of pre-deployment training, right?
Mm-hmm.
And it's really not just military deployments. It could be deployment to humanitarian aid to the civilian world, or even for a military provider. Obviously, if you had all the time in the world and all the money in the world to pre-train, you can construct a training pipeline that is much different than if you are rushed or have limited funds and limited time.
Mm-hmm.
I think it's important to know what the FCCS Resource Limited course can teach and probably what it can't teach. And for the group that's going out the door, whoever's leading that group needs to know what that group needs in terms of the best bang for the buck, so to speak, right? And it could be resource limited, or it might really be something else. So we haven't really talked about kind of what the FCCS Resource Limited course covers too much yet. And maybe this is a good opportunity to just kind of go through an overview of the course, Dennis. Would that make some sense?
Yeah, absolutely. Let's do it.
All right. So the FCCS Resource Limited course consists of a textbook, obviously, and the textbook has, I believe, 21 chapters in it now, and I'm not going to go through and review all of those different chapters, but it covers a wide range of topics related to critical care and kind of disaster medicine. And in that context, it covers some of the basics of critical care. And then it covers trauma, it covers monitoring, it covers some pediatric pieces, some burn-specific pieces, tropical diseases, mass casualties, pregnancy is kind of towards the end, environmental emergencies, kind of some basics about telemedicine, and then it has some instructional guides for how to do some maybe important tasks that you might not otherwise encounter in Western medicine, like peritoneal dialysis as an emergency renal replacement therapy in the austere setting. So that's kind of the basic overview of the book. Again, each of the books is designed to be somewhat case oriented, in that it presents some cases and then it reviews the material and then it tries to talk about those cases at the end with some key points. The course itself was initially, we had a lot of discussions about how long to make the course, whether it should be a 2-day course, a 3-day course, a week-long course. And, again, that's similar to our conversation now about what's the right training to do before you go out the door. There's pluses and minuses to each choice that you make related to creating an education event. So ultimately, we decided to keep it the same duration as any other FCCS basic course, which is 2 days, 2 fairly fully packed days of education. But I will say that as we evolve the course over time, there's expectation that you could incorporate more high fidelity simulation type training within it, and that would probably extend the course because it is case based. If you made the cases more high fidelity simulation and actually required students to do hands-on skills, that would be a variation on the course. And it's actually the way we did the very first course. We did it with some hands-on high fidelity training mannequins and some cases there, and it was very nice. It just adds a lot of time and a lot of complexity to doing a course. So that was the other component of making the actual FCCS final version of Resource Limited. We wanted to make sure that it was accessible or could be taught in a wide variety of places that may not have access to high fidelity simulation or may not have the experience in order to conduct one of those types of those courses. So in the actual course itself, again, in that 2-day course, you have some initial introductory lectures, followed by a case of gastroenteritis in a clinic that we've made up that's in an austere location. You can imagine your least favorite austere location that you might want to practice medicine in, and that's kind of how we encourage people to think about the course. And that in that clinic type environment is the location that you're going to provide care over the next couple of days. So the very first case is of a couple people with gastrointestinal diarrhea, and the students are forced to think about that case and to come up with differentials and to ultimately manage it. One of the key components that's brought up early on in this is the lack of laboratory testing that's available, and the ability to assess with good physical exam skills and maybe an ultrasound if you're lucky, a lot of aspects about a patient's organ perfusion and their ability to maintain homeostasis without advanced intervention. So their probability of doing okay versus not doing okay in a short period of time. After that, we move into some, again, reinforcing didactics, and then talk about infectious disease with emphasis on sepsis and septic shock, as well as mechanical ventilation. This is about the only kind of standardized course that really teaches very much about mechanical ventilation. That's true for the FCCS basic course. And we found from our students in some of our original pilot work that really there's no other good course out there that talks about the basics of mechanical ventilation outside of a critical care or ICU rotation for somebody. So we felt it was very important to keep a lot of the basic mechanical ventilator education in the course. So we do some basic mechanical ventilation, and then we move into a hands-on skill station event, and that skill station event focuses on 3 different skills. One is actually hands-on mechanical ventilation. The other skill station that is mandatory is how do you think about essentially packaging a patient for transport. So it's all the all the thought process that most clinicians don't really go through unless you do transport, medicine for a living, about how to make sure your IVs are functional and that they're accessible and that the, tubes and lines are appropriately tied down and that they won't come out during the transport. And we talk a little bit about, what happens when you go to altitude in that space. And then the last one is a skill that's lost by the vast majority of patients, of people who practice medicine in the Western Hemisphere, which is how to set up an IV and how to mix drugs, and then also how to drip those medications in using the drip counting technique. The reason we've lost that skill is obviously we have pharmacists and we have IV pumps kind of that are ubiquitous in our hospital systems. So many people just don't know how to do those. The afternoon session is composed of a burn care scenario. Happens to also be a pediatric patient. So we talk a lot about pediatric critical care and then burn care. And that is really the first day, and it's very long. And day number 2, we start off fast and furious with a mass cal scenario. The mass cal scenario is not designed to be, overwhelming, but it's designed to be enough that it stresses the resources of whatever group that you are teaching in terms of their ability to think about different roles of care and then support those numbers of patients. And it brings up a lot of great discussion about what to do now versus what to do later, and how to manage that type of a situation in a resource-limited setting. There's some potpourri didactics that can kind of be added at the very end of that scenario. One of the favorites of folks that are certainly not in the special operations community, oftentimes not in the military community, is a lecture about safety and security in these austere locations or third world type environments. And there's many people who in the civilian community who just never have thoughts about their safety and security when they move around on a daily basis. And that's been a good topic for many of the civilian folks who take the course. And then we move in to the very end of the course, and it's actually a test. And everybody for right now is getting the same test. And as long as you pass the test with a 70% or higher, then you get certified as a student of fundamentals of critical care support and resource limited environments. So the reason I bring that up is, again, so that you kind of have a good sense of what the course is and what it is not. So what it is not is some of the things that Doug was alluding to. Is it's not very hands-on as it stands right now, unless you add in additional simulation. And while it has teams that talk and kind of interact, and you have some team-based care, it certainly doesn't extend over any period of time to the point where you have to manage individuals' needs like sleep and eating and those kind of physical challenges of actually doing the patient care. So it just doesn't cover those types of issues. Doug and Dennis, you guys have both actually taught the course. Anything I missed?
Yeah, I think that's pretty comprehensive and a good overview of the course, what it provides, and like you said, what it misses. I would definitely re-emphasize the importance of cross-training non-medical teammates on basic medical skills as part of pre-mission training, and don't wait for that to be something that you do after you deploy, because I know a lot of times commanders would be like, oh, you can cross-train that when we get there. It's harder, and you lose the benefit of bringing those two groups of people together, the medical personnel who've received advanced austere critical care training and the non-medical personnel who've been trained to help them in a, sort of no risk pre-mission walk through or trot through exercise. Basically, every rep that you do prepares you for the real thing, which you hope you never see, but you also don't want, if you do encounter it, you don't want that to be the first time people are working together. We have tons of AARs where people, comment on, we wish we had prepared more, we wish we had trained more together, we wish we were more ready for this.
Yeah, I mean, absolutely. In both, AARs that I've heard of, actual prolonged field care scenarios and just AARs from different courses. Thus far, I have yet to hear somebody say, this needs to be shorter. Right. I need less time to do this.
And this isn't me, Doug, giving you my personal opinion as a physician. I am channeling the comments of, over a dozen, special forces team sergeants who have been through prolonged field care training, who have said, this is important. This makes me feel more confident in the ability of our team to take care of an accident or critical illness should one happen. And it's absolutely essential. And it would, and it was, those comments were what led two commanders that I served under to insist that if they were going to do a week of pre-mission training for shoot, move, and communicate, they were also going to do a week of training for render aid, because that is absolutely the fourth pillar of survival.
Yep, absolutely.
Hey, there's a difference between a thinking course and a doing course, and doing certainly takes. They're both important, but doing takes oftentimes more coordination. It's oftentimes more infrastructure to put on that type of course. So we all too often, I think, settle for the thinking type courses just because they're easier. But the only suffering that occurs when you take the easy way out is yourself when you're actually addressed, or your team when you're confronted with the real world scenario that you haven't gotten the muscle memory and the practice with how to manage. So this is not a replacement for a doing course in any way, shape, or form. But correct. It's a good precursor to one of those courses. And it's got enough. It's got some hands-on. So if if you need a refresher or you're trying to just get something done quickly, it does provide some of those options. And of course, you can add in additional simulation if you have a little bit more time.
Yeah. And you mentioned that a few times. So how easy is it? Say I want to set up an FCCSRL course for myself. How easy is it to adapt the course? Adapt it either to the audience or adapt it to what is actually being done, because it's a set curriculum.
Yeah. So in order to get a certificate for FCCS Resource Limited, meaning that you are a certified FCCS Resource Limited student who's passed the course, because it does provide that. It provides educational credits. You have to do the minimum aspects of the course and pass the test. And there's a pretest, and then there's the minimum aspects, which I've kind of already identified. The only variant you can have from that basic course that I described is which lectures you do in your potpourri kind of didactics at the end, and then again you have to take the test. What we were working on doing before COVID struck is starting to think about actually adding in the high fidelity simulation to all of the different cases that are spread throughout the course. And that has not been completed as a kind of way of augmenting the course. But that is at least from the society standpoint, or for the committees group, that's the next thing we really kind of want to work on. In between, the society has always said if you want to add content to the course, there's no restriction on adding content. So if you did more, you're always allowed to do more. You just can't take away from that minimum set. And then I will say one more piece that's very interesting. The FCCS Basic course has many versions of the course. They have an online course, they have a partial online, partial in-person, then they have an all-in-person version. FCCS Resource Limited, because of its group dynamics, the interaction with others that's so important, was kind of imagined, at least for its initial offering, to all be in person. But through some of Dennis's work, as well as Paul Luce, they have started to create a more online or user-friendly online experience where you have groups that can discuss cases using either a WebEx or a Zoom meeting, and that the initial experience with that seems to be fairly positive. I don't know if you want to talk about that at all, Dennis.
So far, it's been very positive. I think I'm just, as an instructor, I'm just able to able to reach out to better instructors, just because I'm not an ICU doc, so some of those finer points I can't provide. But I can reach out and get the person who actually wrote the chapter to teach the class on their chapter. So that's
without having to travel.
Without having to travel. We've also done split, courses where we'll be in the actual course is in 2 separate geographical locations. So the instructors will have, one group of instructors at both locations, and we can teach the courses to both groups via the internet, on top of being able to reach out to other instructors and not have to pay for travel, have that type of inconvenience. And it so far it's definitely been very beneficial. I would say the only downside is kind of the the infrastructure that has to be in place. Like everybody has to have good internet connection. So if you're in a pretty bad Wi-Fi area or bad internet area, it's going to be pretty difficult.
Yeah, I think, and that's actually one of the big concerns that the society and the FCCS kind of committee structure has, just specifically related to this course, is maintaining quality control. And I think what you just brought up, Dennis, is really important. Again, from a course perspective, in order to get the certificate, you have to do at least the minimum requirements. You have to participate, and in the in-person course, there's certain times when you sign in essentially to make sure that you've been physically present and you've participated. Obviously, with the online curricula, there are other ways of kind of capturing that information. But if you're interested in putting on a course, the items that Dennis just brought up with respect to, making sure that people are available and not missing content becomes very important, especially as you go on to some of these online, more flexible course delivery methods. Of note, the society before now has never allowed non-critical care trained persons to become instructors, but they have made an exception, maybe not an exception, but they've created a new standard for FCCS Resource Limited, because there are many people and clinicians that have delivered resource limited care that are much more expert at delivering resource limited care, even advanced resource limited care, that are not critical care trained. So as we mentioned earlier, Paul was the first non-critical care trained clinician, happened to be a medic who is now an FCCS Resource Limited instructor, and there are several who have followed in his footsteps. I will say, if you're interested in putting on a course, though, especially you have to know your audience, and if your audience is going to include advanced providers, either physicians, CRNAs, nurses, you really should try to ensure that one or more of your instructors has a level of training, or I should say certification. Oftentimes training can exceed the certification training from a variety of folks, especially with respect to experience. But you should have at least, I would recommend the certification training of an instructor that is equivalent to your highest level student, just because that oftentimes negates some of the challenges you might have in a student-teacher relationship in one of these courses.
Yeah, absolutely. Trying to field some of these really in-depth questions can be pretty difficult if you don't have the background to support it.
There's always the answer I don't know, and I'll go find the answer for you. I've certainly done that in courses more than once. So again, if I haven't learned anything about resource limited doing these courses, is that there are a lot of questions that are out there that we actually don't know good answers to. And oftentimes we have to do a little bit of research during the course in order to give the most right answer we can find to some of the students' great questions.
Right. And luckily there's enough instructors out there with the qualifications. At least thus far, I've been able to ask somebody that knew the right answer or the best answer. Is there anything else you'd like to add?
I think you had asked also, sorry, about how to set a course up. If you're interested in taking the course, one of the challenges we have is because it is a brand new course, there's just a limited instructor pool. And the way that SCCM, FCCS courses are designed is that the quality control mechanism for delivering good courses and ensuring people get the right training to the standard of what the course was designed for is to have course directors and course consultants being associated with these courses. And again, there's just a limited number of course directors and course consultants. An FCCS basic instructor does not automatically become an FCCS Resource Limited instructor, largely because of the way that we created the in-person course experience. It's much different. It's not just a didactic course. It's small groups, it's case-based, it's instructor-led discussion, which is a slightly different skill set than just standing up and essentially teaching a didactic lecture. In that context, if you want to set up a course, the best way to do that is to get online, go to the Society of Critical Care Medicine's sccm.org website, search for the fundamentals material, fundamentals of critical care support Resource Limited is listed, and there's some contact information there. As we are setting up early courses, probably for the next year or two, I would highly encourage you contacting the FCCS administrative staff to make sure you have all the resources and the appropriate instructors, directors, and consultants available for you when you set up one of these courses. at least in the near term.
Outstanding. Doug, do you have anything you'd like to add?
No, I think I've said my piece, and Jeremy has spoken a lot of the thoughts that I have about the course. I think it's an important tool for preparing providers of many levels and many backgrounds to go into resource-limited environments, again, of many types. And I look forward to being part of the implementation and further maturation of the course over the years.
It'd be great to say a quick round of thank yous.
Yes.
For this kind of inaugural podcast about FCCS Resource Limited. But it's impossible for a course like this to be thought of, iterated, and created without a whole host of dedicated individuals. And certainly the support of the Society of Critical Care Medicine was integral to creating this type of a course. The user demand from folks like Dennis and Paul and Doug, Sean, Jamie, Roger, there's a whole host of folks that really had defined the need for a course that was like this, as well as some of the civilian folks that are out there that have thought about other resource-limited type courses that are similar to this one. Wilderness medicine societies, and there's a whole host of individuals that were at the society that were starting to teach fundamentals of critical care support in some very resource-limited environments, and we're recognizing some of the challenges that we identified as well. But we had over, 40 authors that produced chapters and course material. Matt Borgman is the co-editor for the book as well as for the course. And certainly, had he not been around, the course would not exist. As well as Janet Throne, who is our FCCS staff member from the society, and is really the managing editor for the overall effort. Janet was amazing of getting this course off the ground and actually making it a reality. And the last group that I'd like to thank is we had two very involved pilot groups. One that was done in the society at Society of Critical Care Medicine's annual Congress in San Diego, and we had about 30 students who showed up and provided feedback, great discussions about how to make the course better. And then we did that again at one of the Military Health Research Symposium conferences, and had another great group of students, slightly smaller group this time, but provided amazing feedback. And without their input, the course wouldn't be what it is today. So a huge round of thank yous. It takes a village to make something like this, and there's still a lot of work to be done. So people who have great ideas about how to make the course better, we're open to your suggestions and would love to hear from you. Thank you again, Dennis, for having us on the call today, and for allowing us to talk a little bit about the opportunity that is FCCS Resource Limited.
No, thank you guys for jumping on and talking with me for about an hour. I really appreciate it.
All right. Thanks, Dennis.
Great. Have a good day.
Thanks, Jeremy.
Yeah.
Bye, everyone.
That's it for today's podcast. Be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy, it's waiting there for you.